regarding to special tests, basically I listed special tests that fall into certain categories. So for dislocation, you have the apprehension test for anterior shoulder dislocation, apprehension test for posterior shoulder dislocation, and sulcus sign. So it is good to know what the special tests are used for as a starting point, as a baseline. If you do not know what the special tests are used for, then you are already at a loss. So you need to know what special tests or what category does the special test fall into. So for example, you need to know that the London's test, Speed's test, and Jurgensen's test are tests for biceps tendon pathology. And so for rotator cuff pathology, you have special tests such as drop arm test, which is not specific to a specific rotator cuff, because then you got to do further assessment. Then you have an infraspinatus test, which is typically muscle selected tension testing. Lateral rotation lag sign, lift off sign, and supraspinatus test. You have rotator cuff impingement test, Hawkins-Kennedy impingement test, near impingement test, and a supine impingement test. And then for thoracic outlet syndrome, you have Addison's maneuver, Allen test, costeoclavicular syndrome test, bruise test, and a hyperabduction test, which is Wright test. Then other miscellaneous special tests or acromioclavicular crossover test, active compression test, O'Brien test, which can assess for slap lesion and also AC joint involvement. Then you have specific glenoid labrum tear test and jerk test. But just knowing what the special tests assess is a major component of being able to be successful on written exam, lab practical exams, and when you are working with your patient. So from this presentation, what questions do you all have?
So it goes on from one point, that's anything fair for the practical?
Yes, sir. Mm-hmm. And written exam as well. And typically, so on this one, more so written exam. On the practical, I think on the lab sheet, I have like an asterisk by some, because I can't assess you on every single thing. So on the lab practical, it's just on the lab sheet, the ones that have an asterisk by for the lab practical purposes. All right. So there's some slides that I'm going to cover in regards to clinical examination and evaluation, especially when it comes to assessing accessory motion. Does everybody understand the patient management model? Okay. And what goes into the patient management model? All right. So just give me a brief overview. Pujan, what does an examination consist of?
The subjective and objective measurements of the patient.
Okay, all right, good. That's good, brief summary. All right, give me an example of a test and measure.
Getting range of motion.
Okay, all right, good. So let's pick somebody, Pujan, to give me a brief explanation of the evaluation.
J Long.
All right, J Long.
So that's like taking all your tests and measures and testing, and just kind of like evaluating what like you're finding, trying to get to like a conclusion, based on your clinical impression.
Okay, so basically evaluation. So you assess. So Pujan said assess and range of motion, right? So now you assess range of motion, and you assess shoulder flexion, and throw out a range of motion. So throw out a range of motion for shoulder flexion. So let's throw something out.
160.
So person achieves 0 to 160 degrees. So how would you interpret that 0 to 160 degrees? What is going to be your interpretation?
It's not within normal range.
Okay, so your evaluation of left shoulder joint complex for flexion, active range of motion, your evaluation would be that it's not within normal limits, or it could be that the person is, I'm gonna use from the term slight, considerable, extremely. So the person may be, you may say slightly limited with shoulder flexion. So that would be your evaluation of those numbers that you got from taking the measurement, okay? Diagnosis, what is the diagnosis? What do you say, Trey?
So your PT diagnosis would be taking everything into account and coming up with a condition, what you think the patient might have. For example, if you have stiffness or pain, lack of range of motion, you might, in your shoulder, you might come up with frozen shoulder as your PT diagnosis.
Oh, very interesting. Very interesting that you said that. So my PT diagnosis would be frozen shoulder. Anybody have anything to add to that?
Decreased range of motion.
Okay, so decreased range of motion of the left shoulder joint complex could be a PT diagnosis? Yes, because we are diagnosing impairments / dysfunctions. So if a patient comes to us with frozen, now if the patient doesn't have frozen shoulder, yeah, we can give a clinical impression that the patient could likely have frozen shoulder, but that's not gonna be our primary, diagnosis. That's not gonna be our physical therapy diagnosis, okay? So if the patient gets sent to us with frozen shoulder, they've already been diagnosed, medically diagnosed with frozen shoulder. Not saying that we can't find something else and have a clinical impression of something else, but our primary physical therapy diagnoses are gonna be the impairments, which is gonna result into our problem list, okay? So physical therapy diagnosis in this case would be patient presents with limited range of motion associated with connective tissue dysfunction and or inflammation of the shoulder joint complex. So typically our physical therapy diagnoses are in our guide to physical therapy practice handbook. All right, Trey, choose somebody for prognosis.
It's just pretty much goes with the plan of care and the kind of interventions they're gonna run through and the timing of it.
Okay, so letting the patients know, okay, this is the plan of care, this is what we're gonna implement, this is how long it may take you to improve or return to your prior level function. This is what I'm thinking, okay? And the patient typically agrees with it, okay, let's go with it. All right, Andrew, choose somebody for interventions.
So, interventions is like the modalities and exercises that you're going to implement that you stated in the prognosis, and those are always subject to change based on the progress the patient is currently making, so it can be updated as it goes.
Good. Are your interventions skilled or non-skilled?
I'm sorry.
Are your interventions skilled or non-skilled?
Skilled.
All right, then. I heard you say modalities. Now, I want you to think about this one. Is modality skilled or non-skilled? Tia, what you say?
I would say skilled. So
Why?
It's all in how you document it. You know what I mean? If you're like, we place an ice pack on this man, insurance is not going to cover that. But if you say, well, we gave him cryotherapy, it changes things.
Then you have to know the why behind the modalities.
Yes.
Do the modalities have a science behind them?
Yes.
If you know the why and the science, then it is what?
Skilled.
It is skilled. But what makes it skilled is knowing the why and science behind it. So if I utilize ultrasound for thermal effects, right? And I set my parameters for thermal effects, then I know the science and why behind what I'm doing and producing thermal effects to a specific muscle, right? Then it is skilled therapy. Now, say if I don't know the why and I'm just doing it, I'm like, man, I'm about to do some ultrasound, I don't know what parameters I'm doing, I'm just gonna do it. Then it becomes non-skilled. Then I really can't bill for it. But if I know the why and science and notate that in my documentation, then it becomes skilled therapy. See, I'm trying to get y'all to think like therapists, right? So I may do chirotherapy, some ice massage or somebody who has bicycle tendonitis before getting them to do shoulder flexion and range of motion exercises. but I'm gonna build it in with therapeutic exercise. That 8 minutes I spent is gonna be time that goes toward therapeutic exercise. Because I'm doing it to lessen their pain with therapeutic exercise. You see? So, ice massage performed, time 8 minutes to biceps tendon, left long head bicep tendon to decrease inflammation and pain with performance of, then I'm gonna list out whatever I have them do. All that's gonna be within therapeutic exercise. So now that 8 minutes gets coupled within the therapeutic exercise charge. Emory.
Outcomes are, it's an accumulation of everything you did, all the test measures, all the treatment from the intervention, and you're forming your outcome after, I guess, your specific duration of treatments and whatnot.
Okay, good. So, for example, you do a 2-minute walk test, the person started, and you did a 2-minute walk test, right? For the 2-minute walk test on the set was 200 feet. With a report of patient reported, say the patient reported 16 on a Borg 6 to 20 scale. So 16 is high, meaning they had, it was very difficult for them. And they come back on a reassessment and they walk 400 feet on a 2-minute walk test, and the board report is, say it gone from 16 to 9 on a 6 to 20 scale. Well, how would you rate the outcomes?
Those are good outcomes.
Those are good outcomes. Good job, Amy. Those are good outcomes. The patient improved significantly. So the outcomes is based on where the person was at initial examination and where they are at discharge. Okay. All right. Good job.
Dr. Carr,
Yes.
quick question.
Yes.
Because I always get this mixed up on the, when we imply the SOAP notes. Is that considered the outcomes, the assessment part of SOAP notes?
So in your SOAP note, and say you discharge the patient with a SOAP note, and you use the SOAP for your note or your discharge assessment note, the outcome is going to go into assessment. Why is that?
Because it's what you got from them after they did everything.
Yes. So it's most definitely not gonna go into plan, all right? Objective, this is your objective data, right? This is your objective data. Your objective data is gonna give you your evaluation. It's gonna lead to your evaluation or assessment. So your outcomes are gonna be coupled in your assessment if you're writing a SOAP note. And then of course objective, that's what the patient tells you. You all need to be familiar with and know the grading scale, how we're gonna grade accessory motions. So we're gonna use the Paris 0 to 6 scale for grading our accessory motion. All right. So the grading of the motion is going to be, again, 0 to 6 scale, where 0 is ankylosed. That means the joint is lightly fused. A grade of 1 is a considerable restriction. It's hypomobility. Considerable restriction for hypomobility. A grade of 2 is slight restriction for hypomobility. 3 is normal. 4 is a slight increase, hypermobility. 5 is considerable increase of hypermobility. And 6 is unstable or instability. Okay, marked instability. Now, how do we get these grades?
Motion getting outside of the resistance of the cartilage.
Okay, Sel say how much resistance you get outside of the.
Not like outside, but like while stretching the cartilage.
Okay, while stretching the cartilage. So if I give my right glenohumeral joint, say the inferior glide, I give it a grade. And say it is my involved extremity. How am I gonna know that it is considerably restricted. So say if I give it a grade 1, how am I gonna know it is considerably restricted with hypomobility? You have to assess the uninvolved side, okay? So you compare the involved side with the non-involved side, okay? So my non-involved side is gonna let me typically know what my normal is or what your patient's normal is. There will likely be a difference in mobility between the non-involved side and the involved side. So that's why we always have to assess both sides when we're doing passive range of motion, when we're doing muscle selective tension testing, when we're doing goniometry, active range of motion, even when you're doing special tests. All right? So for all of our assessments, we have to assess both sides. Okay? That's how we identify normal versus abnormal. That's how we're going to do our grades. Now, when we assess accessory motion, what are we looking for? So we're looking for if that motion is smooth. Smooth motion. The motion should be smooth. That means it should not be aberrant motion. So aberrant motion is motion that is not smooth. It's like jerky motion. So we're assessing for the smoothness of the motion, okay? We are assessing to make sure that the motion doesn't have an abrupt stop, okay? Because of the motion, when we assess the component motion and we get an abrupt stop, what could that mean? That could mean that we have like a bony block. That could mean that we have a loose body somewhere within that joint. So that's gonna let us know that something is not right, okay? We also assessing the infield of that accessory motion, all right? Do we get a normal, tight, capsular infield, okay? Or is it abnormal? But how do we know? We gotta assess both sides. Is an abnormal type capsular infield or is it a normal type capsular infield? We only know that based on assessing both extremities, both joint complexes. All right. And then we grade the motion, the accessory motion. When we look at accessory motion, we're talking about component motion and joint plate motion, okay? Accessory motions, when we perform accessory motion and we look at the accessory motion, is accessory motion more so for examination purposes or treatment purposes? So we want to start off our accessory motion by utilizing it for assessment, because primarily it is utilized to assess. Now, why in the world would we want to assess the component motion or accessory motion?
You have like joint instability, you have like a muscle weakness, like a rotator cuff or something.
Okay, so from that aspect, if a person is hypermobile and they're significantly hypermobile, it could be due to some type of joint capsule laxity, all right? Or it could be due to weak musculature, all right? Weak muscle tendon units, okay? In that case of it being hypermobile. So then if we get a joint that's extremely hypermobile or unstable, then we know we gotta treat this with strengthening and stabilization. So now our assessment is gonna drive our intervention. So that's good, what Seth said. Now, if we think about it from the standpoint of the joint, you assess the component motion, right? And the component motion is restricted. Why is that meaningful to us? Hey? It could lead you to a clinical impression of some type of abnormality within the joint capsule. Okay, so we got classical motion, right? Active and passive range of motion, which are classical motion. How can accessory motion, such as a component motion, impact classical motion? So I perform glenohumeral coronal abduction, right, of my right shoulder joint complex, right? So, of course, we know it takes muscle strength to do that. So, say I don't have any impairments with my muscles, all right? So my muscles are not weak; they're strong. I can get abduction, but what else do I have to get that full abduction in conjunction with muscle strength? The intimate relationship between my joint articulations have to be functioning appropriately as well in order for me to achieve full range of motion. So what does that mean? What has to occur in order for me to achieve full coronal abduction at the shoulder joint complex? So when I talk about the intimate relationship between the joint articulations, what am I talking about? Say again? Osteokinematics. What is osteokinematics? You give me some teachable moments now. So the osteokinematic is the direction that the osseous structure moves in. That's the bone. So is that the intimate relationship between the articulated surfaces? So the motion between the intimate relationship of the articulated structures, what is that referred to? Arthrokinematics. All right? So now, we know that in order to achieve full active range of motion, we have to have good accessory motion. All right? So if my component motion or joint plate motion is restricted, that could lead to a limited classical motion. So limited active range of motion. So now, orthokinetically, when I perform coronal abduction of my shoulder joint complex, what has to happen at the glenohumeral joint? There you go, an inferior glide has to occur. So now we need to know how to assess the inferior glide. You see? What has to occur at the glenohumeral joint with external rotation? Okay, so it's gliding anteriorly. So now we need to know how to assess the anterior glide if someone has a restriction with shoulder joint external rotation. Does it make sense? But not only do I have to look at the glenohumeral joint, whatever, I have to look at what's going on in the acromioclavicular joint. I have to look at what's going on in the sternoclavicular joint. I have to assess the scapulothoracic articulation. According to the Guide to Physical Therapy Handbook, manipulation and mobilization are synonymous terms. They mean the same thing, according to the Guide to Physical Therapy Handbook. Okay? Both the skill passive movement of the joint, basically. Okay? The difference lies within the grades and how the terms are used. Most people want to associate manipulation with a thrust technique. And they want to associate mobilization with grades 1 through 4. And then they want to associate manipulation with grade 5, which is a thrust. So you will hear some clinicians use it that way. But however, according to the Guide to Physical Therapy Handbook, manipulation and mobilization are the same things. So I could do a grade 5 mobilization, right? So basically, if you see a thrust technique, that's a grade 5 mobilization or grade 5 manipulation. Or you got grades, so it's a synonymous term. So you can either use the term mobilization or manipulation, it doesn't matter. But each on a maintenance scale is 1 to 5. The grades of the mobilization or manipulation is 1 to 5. Okay, but we'll get to that. Okay, so manipulating Manipulation techniques are considered more of an art than a science, but there is science behind them, but it takes skill to be able to perform them. And the selection of the technique is going to be driven by the dysfunction or impairment. What in the world does that mean? Driven by the dysfunction or impairment. So now this is where you have to have a strong command of your orthokinematics. All right? You have to have a strong command of your orthokinematics. So if I present with limited shoulder joint extension, active range of motion, and I cannot move my arm backward at all, I'm like, I can't move it into extension. And I need to be able to move my shoulder joint complex into extension. That is an impairment that your patient presents with, limited extension. So now, as a physical therapist, you have to know what orthokinematic motion and the shoulder joint complexes are required for this patient to be able to perform shoulder joint extension, right? So now that impairment of limited shoulder extension is going to drive what technique that you perform. So are you going to perform a posterior glide of the GH joint? Are you going to perform an inferior glide of the GH joint? Are you going to perform a superior? Are you going to perform an anterior glide of the GH joint? Also, the selection of the technique is driven by the desired effects or the outcome that you want to achieve. So if you want to achieve neurophysiological effects, if you want to achieve biomechanical effects, if you want to achieve psychological effects, that is going to also dictate what grade of manipulation that you're going to use. Okay? And also, your manipulation is going to be driven by your competency. So most therapists who are competent with manipulation and mobilization, or manipulation or mobilization techniques, tend to perform them and tend to perform them with efficacy, with effectiveness, and also those with experience. Those who don't have the experience and who do not have the skill or confidence tend to not perform manipulative or mobilization techniques. They tend to stay away from them. So if I put you in the clinic right now, you do a clinical internship right now at the point you are in, at your level of education, are you going to be doing manipulation techniques on patients? Most likely you're not. Most likely you're going to be doing only what you learn in therapeutic exercise, because that's all you know. All right, that's all you had the opportunity to practice. So the fundamentals of mobilization techniques: you want your patient relaxed with the joint supported. As the therapist, you want to be relaxed as well. You always want to locate the joint line. You're going to bunch up the skin before manipulating. Why would you bunch up the skin before mobilizing the joint? So it could be that the skin is taut, right? Because skin can be taut as well, especially if you have scar tissue, if you had some type of surgery. So you want to put slack in that skin. You want to bunch up that skin so that you can actually mobilize the joint, okay? Because it can restrict the joint mobility, okay? You don't want to squeeze or block the joint line. So you want to leave your joint line pretty free. Don't block the joint line. Typically, one hand is going to stabilize and one hand is going to manipulate. One joint at a time is moved in one direction. So one osseous structure is stabilized while the other osseous structure is mobilized. Again, manipulation is a sensory motion. It's not a classical motion. So how does a sensory motion impact classical motion if a sensory motion is hypomobile? It limits it, all right? It's gonna limit classical motion, all right? Now say that if a sensory motion is hypermobile, what is it gonna do to the classical motion? Say again? You may get a lot of movement. You may get more movement than necessary. And then that's when you have to do some stabilization training or strengthening, okay, may be indicated. Now, this is in bold point. Manipulation is most frequently used for examination purposes. Then it may be used as a treatment, but it is most frequently used as examination. Why in the world would I want to use it for examination?
Just to identify what is causing, like, if you get limited range of motion, like what motion is actually causing limited range of motion.
There you go. So wet component motion could be actually causing that limited range of motion, okay, within that cardinal plane. All right. So important considerations with mobilization or manipulation. You want to avoid causing pain, especially if the patient is already in pain. So that's when we want to use our grade 1 and 2 mobilization for neurophysiological effects to abate pain and to stimulate our cutaneous and cutaneous receptors to actually help decrease or abate pain in that case. Examination can become a treatment. So when we do these and we identify problems when we assess our component motion, we utilize that same technique to actually be a treatment. So that technique actually becomes a treatment. Always examine the non-involved joint first. So a patient comes with shoulder pain, right shoulder pain, you're gonna assess the non-involved side first. That's with passive range of motion, active range of motion, mainly muscle testing, muscle selective tension testing, special tests, etc. Use proper body mechanics. Do not have your patient sit on the scooter-rooter. You will fail. If you have your patient to sit on that scooter-rooter, do not have your patient sit on that scooter-rooter, whatever you do. Always err on the side of safety. Okay, use proper body mechanics. So if you are assessing ankle range of motion, right, with the patient sitting on the edge of the plinth, because you're gonna have to do that during your practical. You want to raise the plinth as high as you can with the patient sitting on there safely. So if you're sitting down, you want the joint to be eye level, okay? Whatever joint you're assessing, you want, in that case, you want it to be eye level. All right, so just pay attention to little things like that. Remove excessive jury and consider the condition of the hands and fingernails. So now I'm pretty much all of my patients, I do manual therapy before they leave my clinic, right? So you see my fingernails, how long are they?
They're not long at all.
They're not long at all. Why are they not long at all? I keep them like this all the time because when I'm going to the clinic, I cut my nails every weekend, every Saturday. I cut them, I get them off because I'm constantly doing manual therapy with my patients. I don't want to scratch them. I don't want to poke them with my nails. I actually want them to feel this fat pad. That's the fat pad of each finger. All right, so before manipulation for treatment, you want to do an adequate evaluation. You want to identify the direction of the restriction, bunch up the skin when feasible, prepare the soft tissues, and protect neighboring hypervolus joints. Now, prepare the soft tissues. Why in the world would I prepare the soft tissues before doing a manipulation for treatment?
Increase their extensibility.
There you go, to increase the extensibility of the muscle tendon unit that is gonna allow that joint to move, okay? So typically for treatment regimen, and this is my treatment regimen, I practice this in the clinic. This is like my systematic thinking in the clinic. 90% of your patients are gonna come to you, especially if you work in an outpatient orthopedic setting, 90% of your patients are gonna have some type of connective tissue dysfunction. They're gonna have some type of muscle imbalance, some type of soft tissue tightness that has to be addressed if you want to improve the movement, right? So typically, if I know that somebody has restricted joint mobility, my intervention is gonna begin with soft tissue mobilization. I'm gonna follow that with joint mobilization, right? because now I can move the joint better. All right, then I'm gonna follow joint mobilization with supporting intervention. What are supporting interventions? Therapeutic exercise, therapeutic activity, neuromuscular re-education, gait training, whatever you could think of. Okay? So this is typically my course of treatment, line of treatment in the clinic, but that's what the literature supports. This is what the literature would support you on. Oh, here we go, son. Ooh, this is important right here. I know this is on the written exam. I've seen this on various practice tests. Description of joint plane and direction of manipulation forces. You want to have a strong command of this slide. So the assessment and treatment plane is from the concave surface. You need to know that. The assessment and treatment plane is from the concave surface. Okay, so if you look at the images, you see these concave surfaces of these articulating joints, and you see the lines that are drawn along those concave surfaces. This is the treatment plane. So these little dotted lines represent the treatment plane, okay? So the treatment plane, this dotted line is parallel to the treatment plane. So you see this arrow that's going up and down that has number 2 above it, right here. This arrow that's going up and down that has number 2 above it, that is the arrow that is parallel to the treatment plane. The treatment plane is which plane? Which surface? The concave surface is the treatment plane. So you want to make sure you have a strong command of this. Now, the other arrows represent the type of movement or the type of force. So you see this arrow that says 3. If I move this joint, if I move this osseous structure into this concave surface, if I push it into the concave surface, I mobilize it into that concave surface, I'm compressing the joint. So you get compression of the joint. All right? Now, if I move this osseous structure, so say A2, I'm looking at A2. If I move this osseous structure away from the joint, all right, and I'm actually parallel to that joint and I'm moving it away, what am I doing? I'm distracting, okay? So I'm creating distraction there. So you need to understand what these lines represent and understand the treatment plane is from the concave surface with both this diagram and the diagram below, okay? Now, if I mobilize the convex, now this is a question that you all need to know, need to be able to answer. If I mobilize, say in A1, diagram A1, A2, I'm mobilizing the convex surface on the concave surface. What is the treatment plane? If I'm mobilizing the convex on the concave surface, what is the treatment plane? Concave. It's right there. The concave surface. Now here goes the next question right here. This one's gonna take you for a loop. I wanna see if you can answer this question. Now you go down to the images with B, B1 and B2. Now in this image, the concave surface is being mobilized on the convex surface. I'm gonna see who can figure this out. Now, which surface would be the treatment plane? Concave. It doesn't matter. The concave surface is where the assessment and treatment plane is from. Good. I thought I was gonna trip somebody up with that. Good job. All right. So examining and treating. So when examining, we distract, glide, or tilt to feel the amount and the quality of the end feel of the end range of the motion. So this is with our component motion, okay? All right, and with our joint plate. So when we distract, glide, or tilt, we do it to feel the amount and the quality of the end range. When treating, we take up the skin slack, then we stretch in either distraction, glide, or tilt in the direction of the restriction, okay? And that is where we apply our different grades when we're treating. And here are our different grades. So we got grade 1, our 4 grades of oscillation, or we can say 4 grades of mobilization, or that can be changed to 4 grades of manipulation. But Maitland likes to use the term oscillation because if you get to that range, when you mobilize to that range, then what Maitland is saying, he likes to oscillate within that range. So you can get the person to a grade 2 and then oscillate between grade 1 and 2. I'll show y'all what that looks like in the clinic. You get the person to a grade 3 and then just oscillate the joint between grade 2 and grade 3. Or you get the person to a grade 4 and oscillate in between grade 3 and grade 4. Then you get to grade 5, that's a thrust mobilization or thrust manipulation. All right. So the grade 1 is considered the beginning of the range with a small amplitude. What does small amplitude mean? That means distance, small distance. So if you look at grade 1, look at the distance. You see? So what you will see is amplitude refers to the distance. That's a small distance. How far are we going within the range of that component motion or joint play motion? So grade 1, considered beginning of range, a small amplitude. Some literature would say the first 25% of the range. All right. Then we got a grade 2. Look at how long this line is for grade 2. So what does that mean? Large amplitude. So it's beginning of the range to the middle of the range. So beginning of the range, picking up from a grade 1 to the middle of the range, all right, with a large amplitude, all right. Now, if you go back and now look at grade 3, so the visual is describing what's in the word. So grade 3 is going to begin at the middle of the range and go to the end of the range. But look at this. What does this line represent? The amplitude, the distance. The distance. All right. And now we go to the end of the range, right? With what? A small amplitude. So a grade 4 is at the limit of the range with a small amplitude. So your smaller lines indicate a smaller amplitude. Your larger lines or your longer lines indicate a large amplitude. Now, grade 5. A grade 5 is typically referred to when you see, you may see this term right here. This term is nothing but a grade 5 mobilization. Anybody ever seen this? HVLA? HVLA is very quick. So a lot of speed. So it's going to be high velocity, low amplitude. So it's going to be a high velocity, but a short distance. Okay. All right. So the distance is going to be short. So look at the line. So it's not as long as these lines, right? So it'll be a low amplitude, high velocity, low amplitude, and typically it's the thrust associated with that. That's your grade 5. All right. So what are indications for manipulation? Restricted accessory motion, neurophysiological effects, and disease, if present, is not a major factor, but we want to kind of just notate it. So adverse reactions to manipulation that we want to watch for: increase in pain, an increase in swelling, an increase in muscle guarding, or decrease in mobility, because these are things that we should not get typically if manipulation is effective. So watch out for the adverse reactions. There are several reasons for adverse reactions. Manipulation may not be indicated. You may have manipulated too soon when the joint is inflamed. So acute inflammation could actually be a contraindication. It may not be absolute. It could be a potential contraindication, because if somebody's inflamed, they could likely benefit, or they're inflamed with pain, they could likely benefit from grade 1 or 2. But you have to see what other factors are playing a role within whatever case you get. Okay? It could be that you're too forceful, repeated it too often, maybe not skilled, and maybe the patient not being relaxed. These are contraindications to manipulation. So there are no absolute contraindications, but there are plenty of precautions. So disease states such as an active cancer in or near the joint. So if you have a person with active cancer near or in the joint, you do not want to do manipulation of that joint. If they have hemiarthrosis, what does that mean? So hemiarthrosis is blood in the joint. So if they have blood in the joint, they need to be aspirated, like yesterday. So you would not do joint mobilizations in a joint that has blood in it. This is content that you can see again. If they have hypermobility or they're hypermobile, you want to stay away from joint mobilizations. Why is that? They already have enough motion, all right? So you don't need to do it. It may be that they need something else. And so what is that something else? Stabilization, strengthening of the soft tissue structures around that joint. The contractile soft tissue structures around that joint. Muscle holding. Again, with muscle holding, muscle guarding, we want to stay away from doing the manipulation, right? Because what are we going to do with that muscle tendon unit before we do the joint mobilization? We want to do some soft tissue work to actually relax, get that muscle in a more relaxed state, or to get the muscle down regulated. Okay, all right. Make the muscle more extensible. And again, acute inflammation, I always put a question mark by this one, because this one is a give or take, depending on the case or scenario that you may get or see. But typically, an acute inflammation, typically you will not do manipulation. Of course, joint replacements. Why do joint replacements? Why would you not need to do a manipulation? So typically with a joint replacement, arthritic formation has been resolved, the joint surfaces are already smooth, and typically don't require manipulation, okay? Like anticoagulant therapy, what does that mean? So yeah, a blood thinner, so this person can bleed freely. And so you just want to be cautious to make sure you don't do anything to what that could cause bleeding with this person. All right, when in doubt, don't do it. So manipulating joint replacements, you want to study the mechanical model for motion, if it will permit. If you have a mechanical model that you can practice on, check if possible, if this person has had a successful surgery. Write down a new component in joint play motions and manipulate more cautiously if you have to. And then only after 2 weeks of a well-tolerated active motion, if somebody has a joint replacement. All right. So summary: why joint manipulation? why would we do a joint manipulation or mobilization? So we're trying to restore more normal motion, and ultimately we're trying to improve classical motion. All right, so classical motion and non-classical motion as well. All right, ultimately we want to improve function and performance, abate pain. What does abate pain mean? Decrease pain or eliminate pain. Improve tolerance to insult, and we also want to aid in nutrition and repair. And so these are science behind joint mobilization and manipulation. So our criteria for manipulation is patient position, PT position, loose pack position of the joint. So this is why we want to know the closed pack and loose pack position. So we need to know that we need to have the patient in a loose pack position to assess and treat or perform joint mobilization. Joint alignment is important. So we're going to be talking about joint alignment, stabilizing hand, manipulating hand, direction of force, amount of force, quantity of force. So you have your classification and definition of movements. As PTs, we need to have a strong command of this content. So we need to know that active movements and passive movements are referred to as classical movements. So those are the osteokinematic motion. So those are the directions in which our osseous structures are moving. So when I say osseous structure, what am I talking about? Okay. So the active movements are motions that result from voluntary muscle action, and the passive movements are motions that occur from external forces. So most of the time when we perform a passive movement, we as the therapists are performing that motion. And then for accessory movements, we have what they call component movements and joint play movements. So the component movements are our orthokinematic motions that take place with active motion. So remember, if the component motion is restricted, that ultimately the active motion can be restricted, okay? So that is why we have to assess and know how to assess the component motion as physical therapists, because we are considered movement experts, right? Okay. So what would be an example of a component motion at the knee, like an upward glide of the patella, or the tibia sliding anteriorly on the femur, or the tibia going into external rotation, the fibula sliding up on the tibia. Those are examples of component motion. Then with joint play motion, those are movements that are typically not under the voluntary control of muscle or muscle tendon units. So these occur in response to outside forces at the end of the active range of motion, but they can play a crucial role in the patient being able to achieve full range of motion, okay? So examples of joint play motions are tilts and distractions, and some glides, okay? Some glides, such as at the patella. All right, so we have our manipulation movements. Distraction, which distraction is the separation of two articular surfaces. So if you go back and look at that slide where we talked about the concave surface being the treatment plane, and you look at those different numbers and directions of those lines, and so you see one line moving away from the concave surface, that's when you have distraction. And so distraction is distraction a component motion or a joint play motion? Distraction is joint play. Tilt is joint play, okay? And when we're talking about a glide or slide, then we're talking about a component motion, all right? So, with the distraction are used to unweight the joint surfaces. So typically before our assessments, and also treatment, when we perform manipulation and mobilization, we tend to unweight the joint surface. So what are we doing when we unweight the joint surface? We're distracting it to unweight it. And so it's going to stretch the joint capsule or adhesions, and it's going to assist in the reduction of a dislocation. All right, so then we have non-thrust. On the maintenance scale of mobilization or oscillation, which grades are considered non-thrust? I want y'all to make the connection now. Grades what? 1 through 4. 1 through 4 are your non-thrust mobilization. All right? So non-thrust is a joint oscillation or stretching within the limits of accessory motion. All right? And accessory motion could be component or joint play. Joint oscillation or stretching at the end of its accessory range. And then the use of non-thrust for grades 3 and 4, and also 5, is to mechanically elongate connective tissue, including adhesions. Now, what are the effects of grade 1 and 2 for neurophysiological effects, which is intended to fire cutaneous receptors and joint receptors within the articulated surfaces, within the joint capsule, okay? Now, thrust is a grade 5 on the maintenance scale. So remember I told you it's a sudden high velocity. I use the word low amplitude, but short amplitude motion is going to be delivered at the pathological limit of an accessory motion. So typically we get the person to their end range. So we get them to a grade 4, and then at the end we add a high velocity, like a very fast movement, but it's a short amplitude mobilization at that range. And typically we get some type of release of the joint, some type of audible release, what some refer to as a pop when we do the thrust technique.